These are, yes, sodium channel blockers, triamterene and amiloride. Okay. I don't know if you completed that exercise of the tutorial in which we say what will be the effect of blocking this triple transporter, what will be the effect of blocking sodium and chloride co-transporter, what will be the effect of blocking the sodium channels in the distal tubules. So then you have to see what kind of effects are produced. That's very interesting actually from your thinking or reasoning. Okay. All right. In this area, another group of diuretics is working. What is that? Aldosterone antagonists. Okay, because this is the area of the aldosterone action. Do you remember that? Late distal tubule and collecting ducts. Okay, yeah. So aldosterone is there. If you antagonize the action of aldosterone, well, there will be diuresis. But what will be the side effect of that diuresis? Hyperkalemia. Okay. So the picture goes into hyperkalemia because then potassium is not secreted and sodium is wasted. So diuresis is there, but along with hyperkalemic effect. Okay. Sometime we'll talk about issues. We'll relate the acid-base balance with the electrolyte balance. But first you need to make yourself clear about the acid-base balance also. When you're clear, then we'll see how diuretics are producing the effects. Okay, in electrolyte balance and in the acid-base balance. Okay, now we are going very quickly. That was only an initial discussion. Okay, please look at the sodium balance. Sodium balance means tawazun. Tawazun means you have two ends of tawazun, incoming end and the ongoing end. Okay, so it should be equal. If you are maintaining the input and the output, then you will say, okay, it's now balanced in the body, isn't it? Well, do we have sodium in the diet? We eat sodium, yes or no? Yes. Okay, all sorts of food, but what we eat, they have variations of sodium. Okay, leaving mala, you are not adding the salt. Even without salt, the food that we eat, whether it's meat or vegetables or any stuff, okay, that has some amount of sodium already. And then you also take salt. Okay, anyway, salt comes by a desire. Okay, if you have not had salt for a long time, if you are in the habit of eating salt, we all eat malha because without that there is no taste coming to the food actually. If the salt is not there, you're eating but you're not feeling that taste. Okay, so it is lost. See, only from one little component what happens. Anyway, if you have not been having salt for a long time, then there will be a desire to take. You will develop a special thing. You will have that I must eat something which is salty. Okay, you will crave, and that craving will give you, I think the word is ishtiha. You will have a special desire or looking for salt automatically. Okay, so you will go and you would like to eat those things which are salty. Okay, or this is done by the animals also who don't know about the salt. But when they miss the salt or when they develop a low sodium, they go and they lick the stones with the tongue just in order to find that salt, okay, to get inside, because salt is present in everywhere, okay, in clay, in mud, in rocks, everything. So they take the salt. So we have a special salt appetite center which is present in the hypothalamus somewhere. Okay, so that gives a signal that we need salt, we need salt. Salt should be sought. Okay, so you have to get some salt. So what do you think, when you have hyponatremia or hyponatremia, when will you have that craving for the salt? Hypo or hyper? Hypo. Hypo, definitely. When you are going down in the salt, if your salt is low, in that case. So one thing. Second thing is hypovolemia also. Okay, low blood pressure. If the volume decreases and the blood pressure decreases, then we have some special receptors through which our hypothalamus is stimulated. Okay, hypothalamus has connections with different receptors, and hypovolemia will give you a signal that salt should be taken inside. Okay, hyponatremia is giving you a signal that salt is needed. In both cases, we'll go for the salt automatically. Okay. For the output, it is mainly the kidney. Okay, it's mainly by the kidney. Some of the output is going by the other, sweating and in the feces also, but the main outlet is definitely the kidney. Okay. Receptors are very important. Two types of receptors. I'm going slow, but I just need you to polish your concepts about cardiovascular system and other areas also. There are two terms. Okay. Low pressure receptors and high pressure receptors. Do you have the idea about these receptors? Okay. Low pressure and high pressure. Low pressure means low. Yeah. Low blood pressure means, low pressure means what here? Okay. Low pressure receptors. Where are they present, first of all? Why are you calling them low pressure receptors? This is a question.
When the pressure is low, it's this kind of receptors. It works when the pressure is low.
When the pressure is low, this is the concept. Let us talk about it because it needs clarification. Low pressure receptors. Why are you calling these receptors as low pressure receptors? Abdullah is saying that because they control or they respond to the low pressure. That's why we are calling, as the name is telling us. Do you agree with Abdullah?
They work in low pressure.
They work in low
pressure.
Low pressure. Okay. Now I am getting a little different information from you to Rayan and Abdullah. Abdullah is saying that they respond to the low pressure. That's why we call them low pressure. Rayan is saying something else, a little deviated. He's saying that I am looking at the areas where they are present, and the areas are pulmonary circulation or the atria, and because these areas are the low pressure areas, that's why I call them low pressure receptors. So he's giving the anatomical reason, he is giving us the physiological reason. For this one, what do you think? Physiological? Anatomical? Select one. Anatomical is more close, okay? It is deceiving actually. From apparent look, we think that low pressure means low pressure. That's why. But shuf, these receptors, they respond to the volume changes and they are present in the low pressure areas of circulation. Low pressure receptor means present in the low pressure areas, okay? Whenever the volume increases, these receptors are stretched, they are mechanoreceptors, and they will respond. Now what are they responding to? Low volume or high volume? But they are called low pressure receptors. Why? Because they are present in the low pressure areas of circulation. They are present in low pressure area, but they are responding to high volume. So confusing really, isn't it? But this is anatomical picture. Did you get that? Okay, so don't get confused. They are the detectors of the volume changes basically. High volume changes, they respond easily, and still they are called low pressure receptors because of their presence in low pressure areas, which are yep. Okay, that's why. High pressure is very easy. High pressure means, well, they are present in high pressure areas of circulation, again anatomical mainly, because again it will be confusing. If you are saying high pressure and baroreceptor, what do you mean by that? Baroreceptors, high pressure. Stimulated by the pressure. Good answer. But what kind of pressure? High pressure or low pressure? High pressure. Both. Okay. So I now have three choices: high pressure, low pressure, or both. Baroreceptors work when the pressure is high. Yes or no? Yes. Baroreceptors work when the pressure is low. Yes or no? Yes? Yes or no? So the concept is not clear, or you don't remember it, okay? Half of you are saying yes and half of you are saying no. High pressure, everyone is saying yes, okay? All right, what about the low pressure?
For some limits, maybe 70.
But are they working if your blood pressure is falling down? Is the baroreceptor responding and trying to correct the blood pressure? So they are working in both directions? Yes or no? Yes, they are bidirectional controllers, yes. Yes. Baroreceptors are the bidirection. B for baro, B for bidirection. Means both directions, please. They control the high blood pressure, brings it back to normal, and they control the low pressure, and they bring the pressure, as he's saying, okay, from a level of maybe from 60 or 70 up to like 180 or so. Okay, this is the range. Okay, so it means working in both direction. Your middle value is 100, where you are keeping your pressure normally, average pressure. So from 100 to 180, they will try to bring back. From a falling pressure of 60 or so, a fallen pressure of 60, they will try to bring it up. So both directions. So now, according to this one, high pressure receptors, are they present in the high pressure area, or they are just controlling the high pressure? High pressure area. Okay, so this is according to the anatomical classification. Did you get that? That's why we stood at that slide very long, so that you just revise your concepts. Okay? All right. Okay, very quickly. Sodium is controlled by many factors. Have a look at the list of the factors from 1 through 6. If you are looking at, just have a look. In 30 seconds, just have a look at that list. 1, 2, 3, 4, 5, 6. Now, if you sort these factors, what are the renal factors here in this case? Renal factors, GFR. That's it? 2 factors. Anything else, or was 2 okay? 2 okay? 2 factors are generally considered as the renal factors. So, okay, this group is renal, isn't it? Okay, it's not written here, but in your mind you can easily pick. Okay, coming down in the list. What are the volume factors here? ECF is the volume factor. All right. All right. Okay. All right. This is it. What are the acid-base factors here? pH. And what are the hormonal factors here? From number 5 and number 6, you can see a long list really, isn't it? So you're dividing, you're just categorizing, arranging, organizing a list in your mind. Okay, these factors here, 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 like this. Okay, you're making a list very quick. Okay, so many things are affecting really. Okay, we'll discuss few things out of this. Number 1, which is important really. Okay, I will continue this lecture later a little. Okay, I'll find some time with Abdullah because it needs a little discussion more. I'm going slowly actually, but I have to. Okay, so we are just finishing in 2 minutes or so. I'm stopping here just by finishing the sodium. Okay, now look, a very special term which we have not discussed before, and that term is glomerulotubular balance. Okay, and that shows the special property of the kidney and the glomeruli and the nephron, okay, to control the sodium. If my tubular load of sodium increases to it's a normal load coming, how much sodium will be reabsorbed from my tubules? 65%. And all of a sudden, if you inject more sodium, give a drip of sodium chloride to me, okay, and my sodium levels go very high, then what will be the load of the sodium in the kidney? Increased or decreased? Increased. And maybe, for example, the load becomes double. Okay, the load is becoming double, 2 times. Yani more sodium is getting filtered because I have more sodium now. Okay. Now, what will be the reabsorption of the sodium now? Will it be same or increased or decreased? In order to excrete more sodium, what will my kidneys do? Will they, from the proximal tubule I am saying mainly, because proximal tubule is the main area, 65%. So will there be any change in the 65%? Okay. Well, the sodium is increased, but the same 65% out of that increased sodium will be reabsorbed, and the remaining 35% out of that will go forward. Okay. That 35% is now more because it is more than the normal, and in the end I will excrete more sodium. Okay. But my proximal tubules will behave in the same manner. If my sodium is increasing, the load is increasing, doesn't matter. 65% is fixed. If my load is decreasing, I am having hyponatremia, and now I am having a filtered load of sodium, which will be less load. What will be the percentage reabsorption of the sodium? 65%. So the idea is, the bottom line is that there is a glomerular-tubular balance. Whatever the glomerulus is filtering, normal or increased or less than normal, all cases, what will happen? 65%. This is called tawazun, glomerular-tubular balance. So sodium is not affected. Okay. All right. The second factor is the reabsorption through the peritubular capillaries and the vasa recta. Just like any other area, you have some forces present in the vessels, you have some forces present in the interstitium, and the fluid is going and reabsorbed from interstitium into the capillaries or the vessels, isn't it? So it means the higher pressure should be modued on which side, interstitium side or in the capillary? From interstitium. Remember glomerulus, when the glomerulus was filtering, high pressure was present in the glomerular capillary, so it was coming from capillary to the Bowman's capsule. But this time you are getting the fluid back. So what will happen? From interstitium to, and it's same, about 10 millimeters of mercury, difference of 10. You will see the forces: plasma colloid osmotic pressure, interstitial pressure, capillary pressure. If you calculate, a difference of 10 is the reabsorption pressure. In the glomerulus, for filtration, the pressure is called the filtration pressure. Do you remember that? And here you will call it reabsorption pressure because you are reabsorbing. Okay? All right. Hormones. Quickly. Aldosterone and sodium. I don't think we need to discuss aldosterone and sodium relationship. We know that already. What is aldosterone doing to the sodium? Do you remember that? Oh yeah. Okay. It's reabsorption. It is increasing the number of channels. It is increasing the number of sodium potassium pumps. It is increasing the number of the sodium hydrogen transporters. Yani all transporters of sodium are increased in number, and their activity is also increased by aldosterone. Okay, that is a magnificent work done by the aldosterone. Okay, what are catecholamines? Do you remember that? You know that. Okay, they also have some effect, mild effect on the proximal tubules, and they promote it. We don't mention it actually, but it's a little effect. Angiotensin 2, a very, very important hormone. We know that. Okay, angiotensin 2 has a very special relation with the aldosterone. Okay, who stimulates who? Okay, angiotensin 2 is the chief regulator or the chief controller of the aldosterone secretion. So whenever you have increased angiotensin 2, okay, it always needs a friend to work along with. Okay, so whenever angiotensin 2 is modued in the blood, it will go to the adrenal cortex and knock the door and call the friend that come along, we'll work together. We have to do some job in the body, let's go together and do it. Okay, so they're working together. Angiotensin 2 is stimulating the aldosterone secretion. Now coming to some flip-flop idea, a new hormone, a very special, I don't know if you have done it, maybe yes, from atria, from heart, from qalb. A hormone is released by the atrial myocytes, ANP, and similar peptides are also released by brain and some other areas, BNP and some other special peptides, they have kind of similar action. Natriuretic peptide. Now, what is the meaning of the word natriuretic? So, what will it do? Reabsorption of sodium, or? Yeah, it will promote. So, it will not secrete. Sodium is secreted or not secreted? Not secreted. Sodium is excreted, yes or no? Okay. So, sodium is reabsorbed, yes or no? Sodium is filtered, yes or no? So, secretion is the way. So, now if you want to excrete the sodium, what will you do with the sodium? Inhibition of reabsorption, no, not the secretion, inhibition of the reabsorption. This is what it is doing. Okay? All right. Others are endothelin, PGE2 and all that. Yes, please come in. Dr. Vadan, please come in. I'm finished. I'm done, please. Lala, it's finished. Come in.
One moment, please.
Yeah, sure. The last slide for sodium. Pressure diuresis and pressure natriuresis. What is the meaning of these two words you have done in the CVS? I'm stopping here. This is the last one. Pressure diuresis and pressure natriuresis. Pressure diuresis and pressure natriuresis. With pressure means you're talking about the blood pressure. Okay? If the blood pressure is high, it is acting. What will happen to the GFR? Should happen to the GFR. It should increase. Even though it has the auto-regulation, it can control and it can minimize the effects. But if the blood pressure is really high, it will affect the GFR. Okay? What is pressure natriuresis? When the blood pressure is high, because of the high filtration, what will happen to the GFR, total GFR, which is increased? If the GFR is increased, what will happen to the sodium excretion? It will also. So it means your GFR, your diuresis is also promoting natriuresis. So they go together. Pressure diuresis and pressure natriuresis. Some extra sodium will be excreted if you are having a high blood pressure. Okay? So normally with the normal blood pressure control mechanisms and the normal kidney functions, this effect is very little. Pressure diuresis and pressure natriuresis will not really happen in larger magnitude. But when your kidneys don't have auto-regulation of the GFR, then slight change in the blood pressure will cause a big loss of sodium. Okay? If the autoregulation is there, autoregulation can control the phenomenon of the blood pressure coming to the kidney. If my blood pressure is high and my kidneys are normal, my blood pressure will try to affect kidney and will cause more filtration, but kidneys will adjust these things and they will not allow my blood pressure to have a very large diuresis and natriuresis because they have autoregulation mechanism which can control. But if my autoregulation is not working, it's not good in the kidney, then what will happen? Now my blood pressure is increasing. What will happen to my large amount of diuresis and large amount of sodium loss will happen. Okay? So this is called pressure diuresis and natriuresis. In normal kidneys, autoregulated kidneys, little effect. But when the kidneys are not good and autoregulation is not there, then it has a very special effect. All right? So we are done with the sodium. Please come in, Dr. Kamal. I'm finished. Okay? So we'll continue from here, the same thing. And potassium, the issue is left, and I'll follow. Thank you very much. See you inshallah.